Okay, I think they're in already.
Yeah, I'll try to share on Facebook. Yeah,
Okay, so we start first now. Huh?
yeah, so first.
Okay, good afternoon and welcome everyone to the ELSA MIS and laparoscopic and endoscopic training course for MIS nurses as well as paramedics. Thank you for joining us on a Sunday afternoon. And here in ELSA, we are committed to continue all forms of education, not only for doctors, trainees, but for also for nurses. All right, so we hope this benefits every one of you all, and do ask us any questions from time to time in the chat box, or you can raise your hand and then we'll try to answer them at the end of the session. We've got a couple of topics here which I think will be of interest or of benefit for you all. So let's get the ball rolling by inviting our first speaker, Miss Saraswati. She is a senior endoscopy nurse as well as a senior trainer in a hospital, Fatima Ipoh, and he will talk to us about, will brief us into the whole concept of endoscopy as well as training programs, what we practice here in Malaysia and in my center. Ms. Saras, over to you. You can share your slides.
Okay, doctor. Okay, good afternoon, doctors and all the friends and new nurses. So today, my name is Saraswati Munyanti. I'm a GA nurse in Hospital Fatima. So today I'm going to present about the nursing training for endoscope nurse. So our title is the role, responsibilities, and best practice in nursing. Okay, the introduction to endoscope. Definition: what is the endoscope? Endoscope is we use endoscope, a long scope, thin and tube with a small lens or camera direct into our body to observe an organ such as gastrointestinal tract in detail through the mouth or the anus. Like OGTS means through the mouth, esophagus to the stomach, and duodenal 1, duodenal 2. If the colonoscope from anus to rectum, descending colon, transverse colon, and ascending to the cecum and terminal ileum. So, what's our, as a nurse, play a key role in patient safety, preparation, and assistance. What is our aim is to explain training process role and responsibility of nurses. Okay, first challenges in advanced endoscope nursing is managing complication of the bleeding or perforation, maintaining strict infection control during the procedure, continue equipment upgrading, high stress and workload in busy units, balancing patient care with the technical supports. Okay, role of the post-basic nurses in the department is patient care before the procedure. Perform pre-procedure assessments like vital signs, allergic, and medical history. Before the procedure, ask the patient past medical history like allergic, diabetic, hypertension, because it means to check for any allergy during the procedure after the sedation like the thimericum or methylene. Next is the informed consent. Provide health education, explain the procedure to reduce anxiety for the patient. Most of patients came for the endoscopy. Patient very anxiety about the procedure. So we as a nurse, we explain about the procedure and tell them doctor will give suggestion before the procedure, so they may very relaxed before the procedure. So third is informed consent is obtained. It's very important before the procedure. Make sure we take consent for the patient as agreeable for the procedure. Next is a prepare patient fasting status and bowel prep. So make sure patient fast for 8 hours before the procedure, and bowel prep is clear or not. Second is during procedure. Assist the doctor in handling scope and instrument like a scope, and then the forceps, any other instrument also. Monitor patient vital sign and oxygen saturation like a SpO2. So every 10 minutes, make sure take the observation to prevent any complication during the procedure. Administrate sedation or analgesic according to doctor's order or hospital protocol, and monitor side effect. If let's say give modamicum or pethidine, patient may develop with allergy, inform doctor and give the hydrocortisone before during the procedure. Then maintain SIP technique to prevent any infection while doing PEG insertion. So have to do the procedure SIP technique according hospital policy. Don't invalidate the procedure to get infection for the patient after the procedure. Anticipate doctor's needs and prepare accessory like biopsy forceps, snare, bending, and etc. during the procedure. That is, after the procedure, monitor patient in recovery room from the sedation. That means airway, consciousness, and vital sign. This is very important. If any changes, inform doctor the further management. Provide discharge instruction, example, the diet, medication, and follow-up. After the procedure, tell the patient do not eat. Tell them to drink water first before they start diet, example, like soft diet. And then told patient after the scope, the throat must be very painful. So to drink water first before any diet. So provide educate patient and family members regarding post-procedure sign of a complication. Tell the patient after discharge if they might have a small bowel distended because due to after the colonoscope OGDS, there's an air inflation inside there. That's why they're bloated. It will reduce after a few hours. Documentation all the nursing care, observation, and intervention. Okay. Role of the technical role, handle and prepare the troubleshoot and endoscopy equipments. This is very important about the troubleshoot. So ensure all the connection are secure and the lines is clear and clean for images. Check for the airflow and water flow. Check for the leakage or damage at the nozzle. Check for the J if there any faulty. Please refer to the qualified technician for the repair and check the internal damage together. This is very important. Before we start the procedure, we must check for the airflow, the water jet, and then the J2. So because we don't want any interruption during the procedure. Ensure the proper cleaning and sterilization of the scope and the accessory. Is during the pre-processing for the scope. Maintain equipment functionality and safety check also. Okay, during emergency, recognize and respond to complication, bleeding, example, perforation, and respiratory distress. Provide immediate life support, CPR, during the code blue. Assist in emergency procedure also. Okay, professional development. Keep the updates during the guidelines in gastroenterologist and endoscopy nursing. Like a standardized endoscopy practice to ensure quality care and safety patient, clinic guidelines to maintain the high level of the patient care according to the MOH. Participate in continued training improvement program like a guides, any instruments, new instrument in the department, in the Malaysia or in the worldwide. We have to get to know how to use and how to implement in our department. Educate junior nurses or new staffs. If like a new staff enter the hospital, we will guide them and we'll teach them until they become competent on it. Administrative or leadership. Manage scheduling and patient flow in the endoscopy unit. Participate in audit, infection control, and safety protocol. Okay, now we're going to put new nurses in endoscope. If let's say we have a new staff in our endoscope unit, first thing we will introduce new staff to endoscope nurses and doctor. We will give orientation to the nurses endoscopy unit and the equipments. Example, this is our endoscopy unit. We will introduce them to the equipments. We will tell this is a processor. We will teach them how to on and off, and then how to enter the patient details and name inside the processor machine. And then we will introduce where's the oxygen, where's the suction, liner, everything. And the dynamap to monitor the patient. And where they kept all the scopes in the cupboard with the ventilation. This is our mobile injection trolley. And then our reporting system for the doctors and nurses. This is a mobile to transport our scope after use. And then this is all the equipments we kept, the cloth test inside the fridge, mouthpiece, forceps, bending, PEG items, all is we kept in the cupboard properly. So we will assign a mentor or preceptor for the new staff initial training period for 6 months. They will assign one-to-one teaching method, so they won't be scared, they won't be lonely in the department. So we will have a review. We will tell them to review hospital policy and infection control, PPE, and emergency protocol. First week, we will ask the new staff to observe the procedure, example, how to hold the mouthpiece, position patient, how to take biopsy and flow test. This is basic things we will teach first time the first week. Actually, observant only, we won't ask them to do. Okay, we will teach them how to hold the mouthpiece. This is a way to hold the mouthpiece. Put the patient left lateral. Before that, we will spray patient the throat, the xylocaine spray, and then ask patient to swallow. And then before that, we have to tell the patient the throat will be numb. Then only we put mouthpiece, and then we will instruct patient to breathe through the nose and then insert the scope. Okay. Second week only, we will ask the new staff to position. They will teach them how to position the patient for the OGDS and coloscope, the left lateral, and then make sure the monitor in front of the doctor to review the monitor easily. Okay, before the scope, we make sure attach all the all the nozzle, all the channel properly, make sure it's not leak. And then check for the J, and by the angulator, check for the J of the scope, and then check for the lighting. And then on the suction, check for the bubble. There's a bubbling or not for the airflow, and then do suction and see the suction apparatus is good enough or not. There is any changes in the scope, change the scope before the procedure, because it's not fair for the patient while doing procedure, there's any faulties happen. The second week to the fourth week, we will teach them preparation of the medical equipment. If let's say example, gastroscope, ask the new staff to enter patient data on the endoscope processor, screen and workstation computer, and prepare small incopad and a baseline dynamic, suction, lubricate gel, disposable apron, face mask and glove. When you switch on the processor, attach the scope to the processor, ensure the suction valve and air valve biopsy channel are attached properly, ensure the scope functioning lighting, suction air, and the lines. Prepare medication according to doctor's order, example like domicum, pethidine, or morphine. So ensure biopsy process are prepared to prepare specimen bottle, formalin 10% in saline for the HPE when I take HPE by doctor's order. Second, preparation of patient. So greet the patient, check the patient with the 2 identifier, and talk to the patient to reduce anxiety, and then tell the patient the procedure, how they're going to do, and the patient won't be scared when doing the procedure. Explain to the patient and give privacy for patient when during transferring patient from the bed to the adjustable trolley, and then consides up to safety. And during procedure, when the doctor arrives, ensure local anesthesia is applied. Example like xylocaine 10% pump spray, either lidocaine, lidocal spray to the throat. Position patient to the left lateral with a small incopad under the patient head. Place mouthpiece into the patient mouth and strap it around the neck. Ensure the place throughout the procedure. And then give the sedation according doctor's order. Then start recording. Monitor patient and document patient vital sign every 10 minutes. Take the pictures during the procedure requested by doctor. And then pass the biopsy or snare during the procedure to take HPE or the flow test. Place the specimen bottle which contain formalin 10% in saline for HPE. The post-procedure Ensure specimen portal labeled with the correct name and ID. Ensure HPE form is raised, biopsy for the HPE. Then end recording upon the end of the procedure. Place the scope in the receiver basin after the doctor removed from scope from the patient. Then we have to perform leak test on the scope before the washing the disinfectant. So for the leaking test and manual washing scope, I'm going to tell into the washing and storage. After the procedure, first thing we have to do is wipe the scope with a clean gauze, and then do the suction. With a clean gauze, the universal cord with a clean, and then place the scope in the receiver basin. Connect one end of the leaking test cable to the another end of the scope, and then switch on the leaker test. Observe the universal cord should bubble up. Place the scope into the washing zinc. Fill up the zinc until the level of the water cover the scope. When these things, when before the pre-processing, they mean before wash the scope, we make sure it's wiped, suction done, and the function control is done, and the visual inspection also done. While we do leaking test, we have to check for the J, and then left and right the scope, and then we check for the any bubbling is appear or not. If there's a bubbling is appear, make sure clean the scope as usual. That means washing done. Then inform the sister department and then send for repair. So I'm going to tell about manual washing. When the procedure finished ready, place the scope gently in a zinc. Remove all the valve from the scope. Soak the valve in high-level disinfectant for 20 minutes. Wash the scope with the soap and running water. Brush all the valve ports and angulator with the soft brush. Connect the injector with the scope. Connect the 50 cc syringe to the tubing. Flush the enzyme for 3 times. So every channel we have to flush with the enzyme for 3 times. And then we use a long brush to brush all the channel, and then brush the channel for the 90 degree and 45 degrees with double-ended brush for 3 times also. Rinse the scope under the running water. Then coil the scope properly, soak in high-level disinfectant for 10 minutes. Then flush the scope channel with the high-level disinfectant for 3 times. Remove the scope from the disinfectant solution and place it in a zinc. Flush the scope channel with the tap water for 3 times. Generally, rinse the outer surface for the scope, dry the scope with the blower, and hang carefully inside the scope cabinet with the ventilation. This is a manual washing. If let's say we see other hospital, they have a scope washer, you can put in the scope washer, and then for 24 minutes, and then with the alcohol flushing. This is a scope washer. We can put 2 scope in at one time. So you have to take 24 minutes to wash it. So this is storage. This is a cupboard to keep our scopes. And then make sure the end of the scope at the lens, put the cover either with a sponge to prevent from damaging the lines. So I think behind of me, the storage of the scope is there with the ventilation. So this is a way of the storage. So documentation. Once we're done at the manual washing or with the machine washing, scope detail must be written in our system. Example like scope model and serial number and condition of the scope, whether it's damaged or not. So make sure when written the scope detail, make sure the name of staff who perform the cleaning and date and time of the pre-cleaning, leak test, manual cleaning, and high-level disinfectant is written also. There is any issue or incident like a scope fail, leak test, or damage noted, inform the system immediately, then send for repair. So correction action must taken lah. And then storage location, I already show you before this. Okay, recovery room. If let's say patient after the procedure, they will send to the recovery room to observe the patient for 30 minutes in the recovery. Every 10 minutes, the observation was taken. This is the recovery room. The always patient with the oxygen and the monitor, the SpO2 together. There's a bed and the monitor. Every 10 minutes, take the observation and return it. and then check with the baseline of the before the procedure. There's any changes, inform doctor to further treatment. After 30 minutes, patient gain from the sedations, patient can back to the ward or patient can discharge from the department. We call the ward staff or either clinic staff to ensure hand over the cases. Example, patient condition and vital sign, pass over doctor and nurses report to them. And then if let's say got specimen or flow test, hand over to them and report patient report and pen drive together. This is a patient's property to given to them after the procedure. Then after the discharge patient from the department, clean the recovery area, the equipments as per policy, because the bed sheet all must be removed, everything, and clean with the according to the policy. Okay. After the 1 month plus ready, the 5th week or 6th week, then only we will teach them how to assisting in intervention cases. Example like the bending, polypectomy, bleeding cases. Teach them how to use the clip, spray catheter, histocril, or adrenaline injection, 1 in 1,000 injection, 1 in 1,000. Usually we will take time to teach this because the bending, polypectomy, and then histocril injection will be rare cases also here. Not every time, but lesser cases. We'll take time to teach them. But anyway, the cases around, we will teach them also. Fluoroscopy guided cases like ERCP for ballooning and stenting, removal stone, or including the esophagus stenting. This also a bit less cases, but anyway, we will cases. First thing we will ask them to observe first, then only we will teach them by our guiding, our guidance. Okay, assisting non-GI cases, example like a bronchoscopy, how to do lavage, biopsy, brushing, and cystoscope stand removal, insertion of CBD through the cystoscope, urethral dilatation also. Cystoscope, if we have a lot of cases for timing, so we will very fast, they can catch up on that. Bronchoscope, rare cases also, most of time less. So lavage and biopsy and brushing will take time to them to learn about this case. So preceptor will attach the preceptee until the confirmation, that means 6 months period. If let's say they cannot be learned within 6 months, will extend it for another 1 month or 3 months above. So until they really can do it the cases, then only we will confirm them. Until they really be attached with us. So in summary, in post-basics endoscope, nurses play a special role that combine patient's care, technical expertise, safety management, and leadership to ensure the safety and efficient endoscope service. So this is my topic and my slide. This is our team with our doctor. There is we got 5 GI nurses here. This is a few nurses newly joined our department, still in the learning process with they already attached with the preceptor. Well, thank you so much for listening to our slide and our presentation.
Thank you, Saras. Very good, very comprehensive.
Thank you, doctor.
Okay, there's one question sent to me. For Malaysians who want to go for post-basic training, they all have to go through Ministry of Health, or are there other programs that they can go?
Yes, Minister of Health. We have to go through them. But anyway, we have to attach the endoscopic unit for a few months. Then for at least for 2 years, they got experience. They can apply for the gastroenterologist course. At least two years experience, because they have to go there. Then you have to zero knowledge. It will be difficult for them. At least they got attachment there. They're easy for them to learn also. Very fast they can catch up. They get no knowledge how to do it. So they have to Kementerian Kesehatan lah.
Okay.
Because the program only has in the government sector.
Okay. Okay. Thank you, Saras. Thank you for joining us.
Thank you, doctor. Thank you.
Okay. So we'll move on to our next speaker. Our next speaker is Dr. Masfiq Ahmad, who is the Assistant Professor of Surgical Gastroenterology in Dhaka Medical College. We're very grateful that you can join us today, Dr. Masfiq. So Dr. Masfiq will be talking to us about the ideal endoscopic suite or setting up of an endoscopic suite and unit. Masvik, over to you. I think you're muted, Masvik.
So my slide is visible.
Yep, clear.
So thank you. It's a great opportunity to be present here with these international faculties, and special thanks to Professor Lumantu, Sujit, my friend, and Marx. Is special thanks to Marx. He is connected with me, and uh, I'm an endoscopist, surgical endoscopist. In our Asia Pacific region, surgeons are few surgeons are involved in endoscopy. I think much surgeons should be involved in endoscopy. And the previous lecture, I want to thank Saraswati. It's a very good lecture. I go through all his lectures. It's a very excellent lecture. And one slide is dedicated for her. I'll mention when I present this slide. Uh, I work in, my slide is not changing. Mark, my slide is not changing. The problem? I share it again.
Yeah, I think the icon is right at the bottom once you make it full screen.
Is okay?
Yeah, I can see it.
Now it's changing. So now it's changing?
Yeah, it's changing.
Yes.
Okay.
So I work in this hospital. It's the largest hospital, government general hospital, and 2030 bedded. It's the oldest hospital in Bangladesh, Dhaka, Bangladesh, and many Malaysian students also study MBBS in this institution and working as an assistant professor in surgical gastroenterology. So when we talk about endoscope, is actually see the inside of the GI tract, commonly says, but endoscope is engulfed in many aspects of the surgical field, even in orthopedics and neurosurgery. So endoscope has spreaded all aspects of surgical field, but we are talking about only GI endoscopy. This history has started by Philip Bozzini with a slit lamp. He started this examination rectum and urethra in 1800 centuries. Then Harsovic has developed a prototype of fiber optic scope. Nowadays, we are using actually video endoscope. That is the fiber endoscope. That there is an eyepiece. There is no video endoscopy system on that time. Then the Olympus has developed this prototype. Nowadays, we are using this is the first prototype of endoscope made by Olympus. Nowadays, we are using the same prototype. So when you think about talk about upper G endoscopy, to seeing up to the second part of the duodenum, sometimes third part of the duodenum, with the through oral cavity, it is called upper G endoscopy. I go through some basics. So when you go up to the terminal ileum, it's called colonoscopy or lower G endoscopy. And ERCP is the side viewing scope. We do some therapeutic procedure of the pancreas and bile duct by this side viewing endoscope, and commonly remove the stone from the common bile duct. It is the common disease, but stone, stricture, malignancy, and sometimes palliative stenting also we do by therapeutic endoscopy. So now the capsule endoscopy, there is a camera with capsule, and we usually examine the small gut. This is the blank area or black hole of the GI tract. Sometimes some pathology is missed here, so really challenge to find out. So the capsule is a fancy thing to diagnose this one, and the alternative is the enteroscope. Nowadays, a spiral enteroscope also available to make this enteroscope easier and short time. So we know the forward viewing endoscope has the camera, light, air nozzle. This is the side viewing endoscope, the same principle, but the camera is on the side, and we can so that we can intervene in the wall of the duodenum. You can see there is a balloon come through the working channel, and there is a elevator also that angulate when we cannulate selectively in the common bile duct. So when the nursing training has come, I always imagine this figure that the endoscopic needs many hands, but God has only 2 hands. But this extra hands that has this Durga Devi, that is extra hand is the nurses that we have in the endoscopy suite. And we see the many expert endoscopists visited in the international conference with their nurses because they are much comfortable with these known hands. So the decision comes from one hand, but we need many hands in our endoscopy suite. As we see, the Mark has is a wonderful team that his teammates, nurses, has presented a very excellent lecture. I have enjoyed it. I think all the participants also get some information and get inspired by this training program. So the concept of endoscopy unit has changed in modern era. So initially, when we are thinking an endoscopy suite, that endoscopy is just beside the chamber, a single suite, a single endoscope, and a very small area, just auxiliary to seeing the things. The inspection endoscopy, the regular screening endoscope. But in modern era, the endoscopy is changed because endoscopy become a part of laparoscopy. So the endoscopy suite is transferred to the a complex operating theater, an auxiliary tool for the laparoscopic surgeon. So we surgeons become endolaparoscopic surgeons. So this is the part and parcel, the inside of the lumen, examine the lumen to assisting the laparoscopic procedure also. So this is a video. This is I have video also. This is the patient is actually admitted in the ICU, and we shifted the endoscopy cart to the ICU bed beside the patient and do a emergency EVL. So there the patient is extremely bleeding and the patient on shock. So the endoscopy suite is transferred to the bedside actually. So at the ICU. So endoscopy beyond the endoscopy suite, that also is the reality in nowadays practice. So there is a very old picture, more than 15 years ago. I have go through with my endoscope to the operation theater to assist a professor to remove a foreign body, and I published a book. I published an article, very renowned article, the management of foreign body, upper J foreign body, assisting endoscopy by hybrid technique. It's a very minimal invasive technique. So this is the Govind Raj. He's a surgeon. He's from Chennai. He also put the endoscope on a cart and an ambulance and move thrown to the Chennai and make the endoscope to the not the bedside but the home side of the patient. So that is the also concept is changing nowadays. So when we train any assistant nurse paramedics, we have to think that we need the versatile environmental adjustment to make all the therapeutic procedure happen. So organization of structural endoscopic unit, when you think it, actually we think it the endoscopy suite in a very luxurious building with a luxurious operation theater. So I will discuss this one, and then later I will discuss another one. And so at the endoscopy unit actually lay out of a core area of endoscopic procedure, then the patient recovery area, processing of the endoscope and the storage, and the maximum without the therapeutic procedure. We separate the therapeutic procedure. All the things are done by the nurses assistants actually. They receive the patient, they counsel the patient, and they make the patient ready for the endoscopy and colonoscopy, and they monitor the patient and they follow up the patient. So it's a very vital role as a team member, and it's a very important. Even in the Western country, the surgeons, the nurses are uh, doing endoscopy to assist surgeons also. So this is the basic layout of a endoscopy suite actually. Suite means is a complex room. There is a reception and there is a waiting room and the procedure room, then the observation room, because many times we do endoscopy, therapeutic endoscopy by general anesthesia, or sometimes total intravenous anesthesia, TIVA. So we need monitor the patient, and vitals should be monitored. And in our practice, we always uh, sedate the patient, because in our center, maximum procedure is done as a therapeutic procedure. So this is the commonly staffed position and endoscopic position. It's a very simple picture, but it says a lot of things, because you see the surgeon, the endoscopist has only two hands, and the extra four hand by the endoscopy nurses is a very important, because if when I do any therapeutic procedure, the third hand is very important, because we are in stress, actual instrument, which size instrument, and where it is in the endoscopy suite. The endoscopic nurse are much oriented where this accessories is in the endoscopy suite, because sometimes in the therapeutic endoscopy we have to go plan A, plan B, plan C. So this plan A needs some accessories, this plan B needs some accessories, the plan C needs some extra accessories. So all are actually supported by the endoscopy nurses. And sometimes and many times we ignore the issues that the endoscopy nurses role in the endoscopy suite. I think this training program is much helpful, and uh, making the real picture of uh, therapeutic endoscopy. So this is our suite, you see, but this is the ERCP suite. The extra instrument is the fluoroscopy, CR machine. So there is some issues of radiation safeties, and the the nurses should get oriented with the radiation safety also. And our previous speaker has mentioned all the things. I will include this one, because the most risky, the most exposed person is the main endoscopist. He is stained on the red zone, and all the are in the yellow zone and green zone. So I always recommend that use some dosimeter, TLD meter, to measure the radiation, and 3 monthly everyone should check this the radiation exposure, the amount of radiation exposure, and the safety of the radiation. So in the endoscopy suite, we see there is a endoscopy card, the CR, and the extra monitor is the reporting station, and we can see there is a general anesthesia machine. So the endoscopy suite is the operation theater, the endoscopic operation theater. Many therapeutic procedure is nowadays we do in the endoscopy suite. So this is the postoperative recovery room, just like the surgeon. As we are surgeons, we know the postoperative recovery room, how we designed it and oriented. You see, there is a monitor, patient monitor, and dedicated nurses for this postoperative recovery room. And this is the cleaning and disinfectant area that all are mentioned. And the scope storage and patient spaces. The the life of the scope is actually depend how it maintained. So uh, we always trained our auxiliary staffs and nurses that always take care of your endoscopy like your baby. So I think this is also a way to hang this. Someone said that the universal cable should not be hanged and make a loop here. That should not be done. So there's the equipment. The core equipment of the endoscopy suite actually the endoscopy tower, and then the accessories and the ancillaries. So scope is actually all the scopes: gastroscope, colonoscope, duodenoscope, and endoscope. Accessories is common accessories is biopsy forceps, snare, stent, dilator, and clips. And the ancillaries is the electrosurgical unit, irrigation, pumps, U2 supplement, and imaging tower. And the endoscopist, we talk about that the nurses, the endoscopy suite is their home. Endoscopy suite is their home, and the gastroscope endoscopy is their equipment. So that is discussed the control panel. The basic orientation of the scope. Know your scope very well. That's why you take care of your scope. That is the basic principle. Know your scope very well. That's why you can take care of your scope. So that all the issues are discussed by previous speaker. So I'll just go through the So this is the connecting tower. So someone always ignore the issues that I will just only mention one thing: the cables in the endoscopy suit. I always say that the cables are troubles because lot of cables come in the endoscopy suite because there is an endoscopy tower, there is a ERCP tower, there is a reporting station, and there's another extra monitor is also there. So take care of your cables because cables make troubles. Sometimes there is lot of cables and we are forgot to this one cable loosen and the whole processor becomes stuck. So the orientation of the cables is also important. So maintenance and repairs are also leak test, manual cleaning, all the issues are discussed by Saraswati very well maintained, and safety and troubleshooting also she discussed. So I'll jump it. And this is the common accessories. This is the sphincterotomy you use in the ERCP, and this is the pre-cut needle, and this is the handle of the sphincterotomy. The knowing the handle and channel is very important because there is the channels are very easy to clog, easy to block, and by especially by human mucosa is very sticky. So when it's possible, flush with normal saline. After immediate after the work, even in the channel of the scope, wash with normal saline. You see, this is the balloon. The metal and plastic stand, the commonly used accessories. So the CO2 insufflator, we nowadays CO2 insufflator is the standard in as we surgeons we are very much oriented with the CO2 insufflator because in laparoscopy is in abdominal surgery CO2 is mandatory. So we know all the safeties of CO2. In endoscopy, there is a very little, there's high flow and low flow. You see, if there's the control panel, it's the low medium flow. But in laparoscopy, we actually control the pressure. But in endoscopy, they also control the flow, how much flow it is. It's actually less than 2 liter is, I mean, there's defined as the low flow, and more than 2 liter per minute is they defined as the medium or high flow. So it's the most common biopsy forceps. So this is the disposable biopsy forceps. The issue is that never open the biopsy forceps when the forceps is inside the channel because it will drastically damage the working channel of the scope. This is the snare commonly used, and this is the stent, the various size stent. So very important, different stent is need for different patients. So make this oriented with the different size and covered and uncovered stent with different corner of the cell. So this don't jumble up the accessories like this way. Uh, so it's a staff role and specific, endoscopists to do the procedure, but that is happened and assisted by our endoscopy nurses. And there is some auxiliary staff also, HR, admin. They have also a great role. So I always tell our nurses that take care of your scope like your baby. That's why it will grow, it will not damage because endoscopy is very much fragile and very expensive to actually to service it. And our endoscopy company also reluctant to do service. They are happy to replace it. So one of my book with Japanese colleague Tomoyuki Karube is a painless colonoscopy book that is published 2020. Is a very many endoscopists around the globe is like this technique. Is a painless technique. So we do all the colonoscopy without anesthesia. People talk when we do colonoscopy. I think all the faculties will like this and will join in Singapore World Congress. I think Mark will get one of the hard copy of this book from me. So this is a you see how surprising things happen in endoscopy suit. This video is dedicated to all the participants. You see, there is a whole Nokia mobile is followed by a a young man. He's a drug dealer. He's a Nokia 3310, very famous model. Is a very big one. He swallowed it, and the patient is sent for the laparotomy to remove the mobile, but we remove it by endoscopy. And all this happened with the help of our assisting nurse. You see, we are using a very big snare to hold this uh, Nokia mobile. It's part apart. See, very big snare we using, and with sedation, we remove the whole mobile without doing any injury to the patient. I make it quite forward. So we remove it successfully. Thank you. Thank you.
Thank you. Thank you, Masvik. Very good, very comprehensive and very
So
enlightening.
just yes, sir. Just what I dedicated this slide to all our participants, and dedicated to Durga Devi with lot of hands, and they are our hands. Respect to him. And I was dedicated this slide to Saraswati also. Thank you.
Thank you, Masvik. So for those who don't know, I think Dr. Masvik is quite well known for performing colonoscopy, with very little gas insufflation and very little or none of sedation. So those who are interested always can contact him and then for attachment or something like that. Thank you, Masvik. Thank you for joining us. See you soon.
Thank you. Thank you.
All right. Our next speaker, someone who is very dear to me, a good friend of mine. I had the honor to work with him for many years. He's Dr. Loh Hao Piao. He's a consultant surgeon in Hospital Raja Permaisuri Bainun, Ipoh, Malaysia. And he's also into minimally invasive surgeries, particularly in hernia surgeries. So Dr. Loh will be talking to us about, he will introduce the whole concept of endoscopy. Dr. Loh?
Hi, Mark. First of all, thank you very much, Mark, and also ELSA for inviting me for this webinar. I'm honored and delighted to give a short talk regarding introduction for this for endoscopy. So I share my slide first. Okay, is it good?
Yep, can see.
Yep, right. Okay. So today I'm just going to introduce everyone regarding endoscopy. I'm Dr. Loh from Malaysia, working in Hospital Ipoh now. This is my Hospital Ipoh, where me and Mr. Mark has worked before for quite some time. So disclosure, all images and references to the instrument brands presented in this lecture are for educational purposes and carry no advertising and promotional intent. So outline for today's talk is regarding first of all, definition, brief history, types of endoscopies, functions of endoscopies, basic components of endoscopies, common endoscopy accessories, and also further advances in endoscopy. So we go for the definition. So endoscopy is a minimally invasive diagnostic medical procedure that is used to assess the interior surfaces of an organ by inserting a tube into the body. In other words, in simpler words, means that we're looking inside the body for medical reasons using an instrument called an endoscope. The instrument may have rigid or flexible tubes and not only provide for visual inspection for photography, but as well as for enable taking biopsies and retrieval of foreign objects. And endoscopy is a vehicle for minimally invasive surgery, and patients may receive conscious sedation, so they do not have to be consciously aware of the discomfort. Many endoscopic procedures are considered to be relatively painless and at worst associated with moderate discomfort. Next, let us go through a brief history of endoscopy. It starts from ancient roots of Greek and Roman, where inspecting internal body by using the speculum, which looks like this. Subsequently, in 1805, Philip Bozzini developed this liner scope, which with the candlelight and mirror, basically for rectum and urinary tract. Subsequently, in 1860, Julius Brooke developed this distal illumination system by using platinum filament to light up and to able to see. Follow in 1877, Maximilian needs incorporate by putting focusing optics inside the scopes so that the image that we see can be a bit more clearer. Then in 1895, Howard Kelly developed this proctoscope for rectum and sigmoid colon. 1898, Lang and Melzing, they actually developed so-called this first swallowed gastro camera. And in 1954, Harold Hopkins developed this rod lens lens to increase the imaging efficiency. And in 1956, Dubois Montenot developed this first televisionized bronchoscopy. 1957's Hirschowitz and Curtis and Peter, they developed these first flexible fiber scopes. And in 1970 and continue, the companies all developed flexible instruments for these endoscopies. And in 1980s, they started to focus on developing charge-coupled devices, which has higher resolutions of images to improve the real-time observations. And subsequently, all this development of technologies continues. Next, we talk about types of endoscopes. Actually, there are actually a lot of types of endoscope. If we're talking in a broader view, actually it involves the whole body. Start from the lung will be a bronchoscope. For the stomach, it's called a gastroduodenoscope. For the colon, we say it's a colonoscope. For the bile ducts and the pancreatic system, we say the side scope or the ERCP scope. For the ear, it's actually named the otoscope. The nose is actually a nasoscope. For the larynx, it's a laryngoscope. For the urinary bladder, it's actually called the cystoscope. And lastly, if it's involved the uterus, it's actually called the hysteroscope. But however, I mean, in whole body, actually, there are scopes around if we talk in a general. But for today, we are basically going to focus on these three scopes, which is the gastroduodenoscope, colonoscope, and also the side scope or ERCP scopes. So for upper scope, we basically scope the esophagus, stomach until D1 to D2, probably until D3. Next, the lower scope will be starting from the anus all the way up to the cecum, probably go into terminal ileum as well. ERCP, basically you focus on your biliary ducts. And lastly, for your small bowel, you can use either capsule endoscope or single or double balloon endoscope. So what are the functions of endoscope? We basically divide into diagnostic or therapeutic. For diagnostic, it's for direct visualization, for biopsy, and also for screening, and also for endoscopic ultrasound as well. For therapeutic, we can use it for stenting. We can use it for hemostatic control, like this one, injection of adrenaline, or heater probe coagulation, or argon plasma coagulation, named APC. We can also remove abnormal tissue by polypectomy by using the snare. We also can do myotomy. We can also remove the foreign object as well. We can also put in PEG tube insertion for patient, as well as we can do EMR or ESD for patient as well. So basically, we divide the function of endoscopy to diagnostic and therapeutic. Next, what are the components of endoscope? This is the normal scope that we have a look day in, day out if we are in the endoscopy room. Let us go through the components and the parts of, for naming the whole parts of this scope. This is called the control handle. This is called the light source connector. This is actually, we name it as the insertion tube. This is called the universal cord. This is called the distal tip. This is the bending section. This is actually, we call the boot. This is a hole where we put on for biopsy or we do any therapeutic or diagnostic procedure. We call the biopsy valve. This is actually the water or air valve. This is the suction valve. This is the air connector. This is the water connector. And this small thing is actually the suction connector. And there is a big wheel, small wheel, big wheel, sometimes we call it the up-down wheel. A small wheel is a left-right wheel. And these are the wheel locks. And this is the remote switch for taking pictures, or maybe we want to change a certain view or some special visual image. Lastly, this is called the light guide, where the light will go inside. This is the endoscopy tower. Let us name through this laparoscopy tower. This is called the monitor. This is a video system. This is called a light source and the insufflator system and the suction system, everything all in one. This is actually the water pump and also the paddle. And lastly, this is actually the colonoscope. Let us go through, have a look through the usual scopes that we usually use in the endoscopy suite. First one, this is the upper scope or the OGD scope. This is how the tip looks like. It usually measures around 8 to 10 mm, and then it's slightly smaller than the colonoscope. And basically, it's used to scope from esophagus until D2 to D3. This is a colonoscope where you can see the length reach until 180 centimeter. And you can see the tube is actually, the diameter measures around 12 to 14 mm. Why? Is because the suction hole is actually slightly bigger compared to the OGD, because during colonoscope, we might need to flush and also suck out a lot of these thicker materials. And it's actually scoped from anus until the terminal ileum. Next, this is actually a therapeutic upper scope where there are two channel hole over here where you can put two instruments into it. So that's why, although this is so-called the therapeutic upper scope, although it's an upper scope, but then the diameter will be slightly bigger. This is a side scope or the ERCP scope where you can see the tip of the camera and also the lighting system is faced toward to the side. Why is used? Why is like that? Is because that it is enable the for the endoscopists to scope from the ampulla, bile ducts, and also the pancreatic ducts. Next is this double balloon enteroscope, where we use it to scope the small bowel. This is how it looks like, and it's actually the endoscopists must know how to use this push and pull method to actually navigate through the whole small bowel. There's a double balloon and there's a single balloon. So both of it actually is used for scoping the small bowel. These are the differences features between the OGDS and colonoscopy. The scope length for OGDS is slightly shorter. Diameter is slightly thinner. Access road is different for OGDS and colonoscopy. Preparation for OGDS, you only need to fast, but for colonoscopy, you need to give bowel preparation, and but then you no need to fully fast the patient. You can still allow clear fluids for them. Sedation for OGDS, you might or might not give, but for colonoscopy, for most of the time in Malaysia, actually we give patients sedation. And the duration of procedure for OGDS, if it's just for diagnostic purpose, is actually faster, but for colonoscopy will be slower. So what are the common endoscopy accessories instrument? This is the biopsy forceps. This is actually the injection needle. This is the hemostatic clip. This is actually the stone retriever basket or net, or sometimes we also use it to retrieve the foreign body. This is the endoscopy snare. This is actually the grasper for foreign body. This is the argon plasma coagulation or the APC. This is the endoscopy bending for varices. And this is the sphincterotome for ERCP. And this is the balloon for stone removal during ERCP. And this is a controlled radial expansion balloon for any strictures. For this device, most of the time we just name it as CRE. Sometimes some stones are quite big. You would actually use this manual stone lithotripter to actually crush it to make it smaller. This is an endoscopic brush for cytology to take some to brush out some cell during the ERCP so that to send for cytology. What are the further advances in endoscopy? So now we have enhanced imaging technique to actually improve the viewing and also to get a better diagnosis during our scope, which include this narrowband imaging, blue light imaging, which actually and AI, this autofluorescent imaging, where when we put on these special images, we can actually detect the lesion or the tumor growth, which is very early in a better way. And also now there are 3D the scopes as well to actually improve the viewing and also the imaging, the maneuvering of these endoscopes as well. Next is in vivo histological imaging, where this something called CLE, confocal laser endomicroscopy, or this endocystoscopy, where we during the endoscopy itself, we do not actually need to take out the tissue biopsy already. We can actually just use this CLE to directly view on this bowel mucosa, and we can actually just have this imaging where it seems like you're doing this histology slide, and we can read the whole cell, the mucosa itself, and we can determine itself whether the lesion is actually have a malignant change or not. Lastly is now we are talking about artificial intelligence, where there's a computer-aided detection and also computer-aided diagnosis, where during the scope itself, we can actually use this AI to actually help us to give us the definitive diagnosis during when we are doing scope. So as conclusion, endoscopy is a remarkable medical development, replacing the need of doing open surgeries for certain procedures. However, besides endoscopies, running a good endoscopy unit requires a good and skillful team, including the endoscopists and also paramedics and nurses as well. That's all for my presentation today. Thank you very much.
Thank you. Thank you, Lo. Very straight to the point, easy to understand, easy to grasp. Okay, we'll take questions later. If there's any questions for Dr. Lo, you can always email to us or ask at the end of the session. So thanks, Chief. Thanks for your talk. All right, moving on to the next talk. Unfortunately, Dr. Sean has expressed his apologies for not being able to attend. So I will be taking his slot on his behalf, and we'll be talking about OGDS and colonoscopy, and I'll mainly concentrate on troubleshooting because many of these topics slides will be repetitive or recycled. So I'll move into the more specifics of troubleshooting. All right, we all know very well that the role of endoscopy has really revolutionized clinical practice. Just through endoscopy, various procedures can be life-saving, and we can, to some extent, reduce the morbidity of the patient. And because it is a minimal access method, the outcomes are really good, right? So as far like all our speakers have mentioned, we have the OGDS, colonoscopy, cystoscopies, ERCPs, so on and so forth. But for today's topic, we'll be concentrating on the OGDS and colonoscopy, and probably talking more into how to troubleshoot during the procedure. All right, so as we all know, OGDS is an examination of the esophagus, stomach, right up to the proximal duodenum, sometimes up to even D3, okay? And the procedure can be diagnostic or therapeutic. Traditionally, you can diagnose common conditions like gastritis, GERD, ulcers, variceal problems, as well as gastric tumors, and therapeutic procedures by removing foreign body, control of variceal bleeding ulcers. You can settle the problem of polypectomy there and then. There's also use of endoscopy by creating a feeding tube, okay, percutaneous endoscopic gastrostomy, or PEG, where it's more commonly known. We also can extend these services or this technology to cases of pancreatic pseudocysts, where through endoscope, the cystogastrostomy can be done. And now many centers are even going into EMR and ESD. All right, so there are not many contraindications with regards to OGDS. Basically, someone who is unstable, who's got very bad COAD or asthma, which endoscopy might trigger an attack. Patients who've got recent myocardial infarctions and are very unstable atlantoaxial joints, where the patients may need to bend their neck, flex or extend their neck. And of course, uncontrolled or untreated bleeding disorders. All right, a couple of things that we need to do before we move on. First and foremost, to get the patient ready, apart from the surgeon or the endoscopist explaining the entire procedure, sometimes these patients tend to trust or to have different kind of confidence on the nurses. So it's quite all right, and it's advisable for the nurses to just explain the procedure again, and basically how the procedure is run, how long it will take, just to comfort the patient. A consent is a must, okay, and then best taken on the day of procedure. So the attending nurse should keep an eye on this and make sure the consent is done before the procedure is started. Like what Dr. Low said, overnight fast, 6 to 8 hours, or at least 6 to 8 hours of fast. Be wary about antiplatelets or anticoagulants. If purely diagnostic, it's okay, we still can proceed. But if there's any advanced procedure, then best to keep an eye on the bleeding levels of the patient, right? We always advise patients to come with a companion or someone alone, because all our procedures now come with sedation. So it's best for them to go back with someone who can look after them. All right, complications. There come some common complications which are self-limiting, and some complications which are quite devastating, and very rare complications. So common ones will be like pain, discomfort. They may have sore throat after the procedure. Some may not tolerate the lignocaine spray. They may feel bitterness, retching and coughing. In an untrained endoscopist, you may cause some kind of mucosal erosions, some amount of bleeding, you may encounter. And of course, because we insufflate air, they tend to have this bloating sensation, usually self-limiting. And rare complications such as perforations as well as aspirations, which can be overcome if you really go through proper checklists and take a note on the patient's history and current condition. So on the day of the procedure, once registered, they are admitted to the endoscopy scoot. The nursing staff should check the actual indication, consent, and other important prerequisites that's required. Over the years, I've noticed the more senior the nurse, okay, they take account into the proper indication. Sometimes the patient may come with something else, and and then sometimes in a very busy center you may miss a thing or two. So these nurses will help remind you of other added procedures that you need to do. Definitely it's a must. You must take the vital signs before every procedure. Ensure there is IV access. Very proud to say that my nurses in the endoscopy are all top-notch IV access. They're very good. They do this on a day in, day out. No matter how difficult the vein, they can always puncture it. And then once we give the sedation, we always get one nurse to keep an eye on the patient. After the procedure is done, some patients do require reversal, some may not. Patient after the procedure be sent to a designated recovery room with continuous vital signs monitoring. And after a series of checklists and after half an hour, to discharge the patient and make sure they fit all the criteria and all the checklists are checked. Just show you some couple of pictures that we encounter on a day-to-day basis. First and foremost, esophageal varices. Patient with liver disease, they may come with hematemesis, or maybe they come for screening. So this is what we usually see. Very bad cases may extend into the varicose growth in the fundus. They, depending on their grade, they will require gastric banding. It's another common procedure that we do. This is just a simple picture showing it how is it done. So a trained nurse should be able to fit in all these things and make sure all the fittings are adequate, make sure the set is available, and to guide the endoscopist into a smooth and safe procedure. All right. Sometimes we do sclerotherapy, very rarely. Okay, so using sclerotherapy has its good and bad. Bleeding can be a problem. More importantly, improper handling of this sclerotherapy can damage your endoscope. So senior nurses are very, very aware of this. They know how to adjust the scope. They know how to guide the endoscopy so that we prevent back dripping of this sclerotherapy into the scope. Okay, once a while we get patients with biliary vasculitis, small tears in the lower esophagus. Most of the time self-limiting, nothing much need to be done unless there's gross bleeding. Peptic ulcer, commonly seen. Duodenal ulcer, commonly seen. Bleeding ulcers, we do occasionally get them from time to time. So it can be a very stressful condition, especially in the ICU, where patient who stays long. Junior staff may tremble or may not assist in the right way. So be familiar with the procedure and keep all the adjuncts that you need close by to you so that everything is within reach, especially if you need to move your endoscopic tower to the ICU or to the patient's ward or the OR. So make sure everything is taken together. And be familiar with what are the options you have, common ones like adrenaline injection, endo clips, coagulation, APC, and things like that. So be aware of what you have with you. And if you don't, do alert the endoscopist early so that necessary steps can be taken, like what Dr. Musfik said. There's always a plan A, B, C, and so on and so forth. Other forms of treatment will include, like what I mentioned, endoscopic clip application. We mainly use for bleeding, or sometimes during colonoscopy when you retrieve or remove a large polyp, you're a bit worried about the site in which the polypectomy has been done. You can apply a couple of clips just to make sure the mucosa is well opposed. All right, adrenaline injection on the right, you can see the needle. So be very careful. New staff, sometimes they are not aware when to open the needle and when to close it, and how much to inject and things like that. So over time, it is good to familiar and then to follow orders and to familiarize with these procedures. Here's another picture showing you for bleeding ulcers. So apart from injection, we can always apply coagulation and the APC on the right. Okay, sometimes we use some hemostatic powders. Okay, Not very often, but sometimes we do have it. It too has its own problems where, improper use or handling, okay, these powders tend to backflow and may obscure your vision or even damage your endoscopy. Okay, just some couple of pictures. I'm sure you all are quite aware. You see that on a daily basis. Gastritis, gastric cancers, endoluminal cancers, or even cysts. So biopsy forceps is a commonly used tool in the endoscopy. Be familiar with what are the types, the size, how big they are. Okay, so all these things need to be handed down to the juniors and to know where it's all kept so you can facilitate the procedure easily. Just another picture showing you what else we can use this OGDS for: diagnose hiatus hernia as well as reflux disease. Okay, like what Cyrus mentioned, flow test is almost every case that comes for OGDS will go for flow test. So be familiar with what are the types available in your center and how to use it and how to read the slide. All right, so moving on to troubleshooting. Very broadly, we can divide them into pre-procedure problems during the procedure, as well as after the procedure. So for pre-procedural problems that you may encounter is largely due to the patient condition. Just do check whether they are hypotensive or hypertensive. Check their oxygenation, make sure they are alert and conscious. Most of the time when patient comes on a daycare basis, comes as an outpatient basis, they tend to be okay. But when patients are referred to as an inpatient, sometimes they are they are not very stable, and they've got a lot of medical conditions associated. They may come with oxygen. So take a note on all these things. Many times, the first attending will be the nurses. So when you see this kind of condition of the patient, do highlight to your attending endoscopist so that they are aware and necessary steps can be taken. Too low a BP, not advisable. Too high a BP, not advisable. And oxygen is an important thing. Patient who is unstable will require oxygen. Unless they're requiring face mask or intubation, best for them to be stabilized before sent for the scope. And of course, altered GCS is a very important part where you need to pay attention. Okay, during the procedure, I've divided them into mechanical and clinical components. We'll go through the mechanical one by one. So mechanical is basically anything that you may encounter that malfunctions or doesn't function as like what you want. So in sufflation, couple of things, always start low and then move on to medium and high rather than going directly high. So one problem that may occur is overinflation. Sometimes in elective cases, probably not too bad because the endoscopist is well aware of the patient. Emergency cases, sometimes, bleeding and things like that, inadvertently, endoscopists may overinflate the patient, and that may cause a lot of discomfort, hemodynamic instability. So it's okay for you to just remind the endoscopist that there's a lot of air going in. So let's just be careful. One common problem where we have is the suction valve or the air water valve, which malfunctions or doesn't work well. So keep them close by, stand by, so that if it needs to be changed, it can be changed easily. Suction apparatus, sometimes not enough suction power to aspirate whatever gastric or colonic contents. So make sure you have a backup nearby. Be aware of biopsy forceps. So when you don't handle them well, okay, there's a chance you may damage the scope, and you may get it stuck during the procedure, and those are sometimes can be not very comfortable. Another problem is the J maneuver. Sometimes these scopes don't function well, and you're not able to do a J maneuver. We do sometimes get ulcers, bleeding ulcers, or some biopsy that needs to be taken at the fundus. So the J maneuver is very important. Some of hospitals do send their endoscopy directly to the distributor to get it repaired. Some of them go through third parties, so be very careful. Third party companies or agencies, they may not repair the scope as how you want it to be. So always be aware of these problems that may encounter. Clinical signs, clinical part of it is, of course, first and foremost, vital signs. Always keep an eye on the patient's vital signs, BP, pulse rate, oxygenation. Sometimes during the procedure, many of us will start off with a very low dose and then slowly work our way up. So, you know, in sometimes a very bad case, patient may be over-sedated, or patients with liver disease may not tolerate this sedation well. So always keep an eye on that and keep reversals nearby in case you need to. Sometimes patient may come with something but end up complicated with something else. For example, like a polyp may, you know, complicate by bleeding. All right, so keep all these necessary adjuncts close by: adrenaline injection, cautery or endosclips, and very rarely perforations, but be aware of how it looks like. Sometimes you may miss it in a patient who is restless and things like that. So do keep all these problems that you may encounter in your mind. Post-procedure, once again, vitals. Some patients may be okay during the scope. Some patients may not. Some of them may be over-sedated. So you may need to alert your endoscopist whether you need to reverse the patient. Very commonly seen a bit of pain, discomfort, and abdominal distension. Usually by the next 15, 20, 30 minutes, all these problems will be settled. Right, moving on to colonoscopy. Is basically the examination of the colon, and it is actually a retrograde examination where we move backwards from the anus right up to the cecum, and sometimes you may need to intubate the terminal ileum. So all patients must undergo bowel preparation. Common diagnostic indication will include simple bleeding, rectal bleeding. Patients come with iron deficiency anemia, you need to investigate. Patients with persistent diarrhea, or patients who have got cancers who need surveillance, or patients who have got polyps who need surveillance, you need to do it. We also use it to assess or to biopsy patients with irritable bowel diseases as well as inflammatory bowel diseases. All right, once again, this is how we divide them for easy memory and for easy to teach. Is we divide the indications into diagnostic as well as therapeutic. So to diagnose colorectal cancers, you can diagnose hemorrhoids, colonic polyps, inflammatory bowel disease, simple or complex colitis, ulcers, as well as angiodysplasias, and therapeutic procedures such as polypectomies. You control any bleeding from the inflammation or ulcer. Some patients do come in with pseudo obstruction, so it's good we can use this to decompress the colon. So it's almost the same as OGDS, the way you get the patient ready. The only thing is since we're dealing with the large intestine, some amount of dietary modification should be done. So this is what we do in our center. So 1 or 2 days before, we put them on a low residual diet. And on the day of scope, you are still allowed some clear fluids, some nourishing fluids. You put them on bowel preparation. We mostly use Fortrans. You fast or allow some fluids from 12 midnight. Same thing, admit to the endoscopy suite, check the consents. There's a list of checklists that I'm sure many centers will have. Check their vital signs, IV access, prepare the sedation, and once the procedure is done, okay, a proper place for observation, and then discharge following your hospital criteria. So complications, common ones will include abdominal discomfort, bloatedness, pain, all right. Some of patients do experience hypotension, vomiting some, and bleeding and perforation is what we try to avoid as much as possible. It's showing you some common pictures that we encounter. Colonic tumors, we'll see in patients with inflammation. All right, polyps, another common procedure that we do, polypectomy. Just simple picture, I'm sure many of y'all are aware. All these patients will undergo a snap polypectomy. So keep all the adjuncts close by so that during the procedure, you don't need to go running around looking for it. Patients with hemorrhoids, another common condition we see. Not so common, but we do come across it time to time, is ulcerative colitis and Crohn's disease. Sometimes, occasionally, very rarely, you get some angiodysplasias here and there. Colitis, depending on the patient's condition, you do also get them from time to time. Diverticular disease, be familiar with all these findings so that you can alert yourself, you can update yourself, and you can always have a healthy discussion with your endoscopist. So coming back to troubleshooting, once again, to make it easy, divided into pre-procedure, during, and after procedure. So pretty much the same for OGDS. Check the vital signs, make sure they are stable. One important thing is bowel preparation. My nurses here are pretty good at checking on the bowel preparation. I'm aware that some people do continue with the scope and they do a washout during the scope. But the problem is this, is always put the patient at risk of perforation. Your vision is obscured, you can't see the mucosa properly. So there's always a risk of perforation. And because the bowel is not well prepared, you may miss lesions along the way. Long-standing patients, elderly patients sometimes do come with perianal wound or sores. So that can be a very painful condition. Anal fissures, another painful condition. So if you can delay them for a while, do alert your endoscopist early. All right. So during the procedure, same thing. For easy understanding, divided them into mechanical and clinical. So in mechanical, insufflation is an important part. Sometimes we insufflate, sometimes we don't. I don't think we have come to Dr. Musfik's level of doing it without insufflation, but most of us use some amount of insufflation. So, like I mentioned before, when you're doing a procedure, polypectomy, biopsy, sometimes you don't realize you actually insufflate more than what you should. Once again, suction valve, air water valve, make sure they're functioning well and kept nearby. Suction, biopsy, forceps, and something else with regards to colonoscopy is looping. All right. Senior nurses, experienced nurses, just by looking at the scope, how it's going, they already know this is going to loop or not. And when it loops, they know how to troubleshoot. So it's a very important thing to be aware of this. So what is basically looming? When you do the colonoscope is long, slender, and it tends to not, sometimes doesn't follow the colon. So sometimes you may form a loop in the abdomen, right? And common areas are sigmoid colon, and less commonly, sometimes patients with a redundant transverse or a suspended transverse that may lead to looping. Now, it is actually a problem. Okay, it causes a lot of pain and discomfort, and this is because as you keep pushing the scope without knowing that it's looping, it's going to cause a lot of distension, stretching, and lastly, something that you don't want, perforation. Just another picture showing you those ones in the red arrow is where the loop tend to occur commonly, and just the different types of loop that may occur. So most of us tend to see it early in our careers, but as time goes, we know how to rectify and know how to overcome these problems. So as a endoscopic nurse, I mean, it's good to know that you can overcome loop, particularly those nurses who work in high volume centers, training centers where many trainees come in. I don't think it's wrong for you to just help out the trainees sometimes when they encounter looping. So few things that you can do is, first, always withdraw and try entering again. Always reduce the amounts of insufflation that you give, because when you insufflate too much, the flexures tend to open up, so it's more difficult to push. You may change the position of the patient a little bit here and there, and the most common method that many of us use will be the abdominal compression. So a very experienced nurse will know how to roughly play around with the abdomen so that they know, they know how to maneuver and all that to bring it back to its original position. Clinical, same thing. Vital signs, keep an eye on hypotension. This occurs when you over insufflate the colon. There is a reflex vagal stimulation. and that will end up with a hypotension because of the reduced venous return and all that. Sometimes you may experience hypotension. So when you reduce the amount of insufflation, usually it is self-limiting and it settles on its own. Be careful of over-sedation. And once again, bleeding cases, keep all this adrenaline injection, cautery and endoclips nearby. And lastly, perforation. If you do notice, do tell your endoscopist. Sometimes small perforations can be treated with endoclips. Okay. Post procedure, pretty much the same thing, but as opposed to the OGDS, patients with colonoscopy tend to suffer more distension. So you can keep some dispatio close by to help them ease all this excess air. And apart from that, rarely take note on patients with bleeding as well as signs of perforation. All right. So I'm going to summarize by saying that the more you assist, the more you do, you develop all this knowledge, you acquire all this knowledge, and you can pass on to your team. And always be alert. The procedure may be short, but a lot of things can happen within that 8 to 10 minutes. So be alert, be attentive. We all work as a team. So if you see something that is not right, or the endoscopist must have missed something, don't be shy or don't be afraid to tell them, and constantly update yourself through programs available in your countries. So with that, I thank you very much for your time, and take some questions now or later, depending on, or you can send your questions in the chat. Okay, so moving on to the next speaker, another good friend of mine, Dr. Mona Sundaram, who is a consultant HPB and general surgeon in Sunway Medical Center. Mohan and I go way back from typing
Hi, Mark.
days.
Can you hear me?
Can. So,
Okay, good.
so Mohan will be talking to us about ERCP. He does a lot of ERCP. So how you troubleshoot and how you overcome this thing. Okay, Mohan, over to you.
Okay, Mark. Thanks a lot. Let me first share my screen.
Yeah.
Hopefully. Can you see my screen now?
No, nothing yet.
No. Now?
No.
Not yet. Okay, wait. 1 minute. How about now, Mark?
No, let me just check if you are co-host already, right?
Yeah, I should be. Yeah.
Yeah, you're the host already. I think you need to open up your PowerPoint, then go back to the Zoom, and then
Open up my PowerPoint.
you
Okay,
can minimize this, open up your PowerPoint, and then go back to that.
Okay, I've already opened up my PowerPoint.
Share.
Okay, let's go again. Okay, let's share again. Can you see now?
Yeah, okay, now I can see.
Okay, right. Okay, let me just. Okay, can you see my slides now?
Yeah, Mohan, can see. Clear.
Okay, right. Okay, Mark, thanks a lot. Thanks. Anyway, so I'm Dr. Mohan. I'm a HPB surgeon, currently based in Sunway Medical Center, Damansara. So I've been given a task to talk about ERCP, kind of like share some experience and also how to go about troubleshooting whenever we are doing this procedure. And first of all, I'd like to thank the organizers and also ELSA for giving this opportunity. And then maybe after the presentation, if anyone has some questions, then we can share our experience. Okay, so basically my talk, the overview, which is a brief introduction, why we do ERCP, what are the preparations that we need to do before we do the ERCPs, some tips on troubleshootings, and also my talk will be mainly concentrating on ERCPs for problems in the bile duct. So the common problems that we face are stones. So majority of my talk will be more skewed towards addressing the problems when we are dealing with or managing the stones in the bile duct via ERCP. Okay, so basically, I think most of us know it is dealing with pathology in biliary and pancreatic ducts using a duodenoscope, and we access the biliary system via a tempula. Definitely, learning ERCP and performing ERCP requires a different set of skills compared to the learning about OGDS and ERCP. And of course, always one has to keep in mind the effect of radiation, because you know, the fluoroscopy, we sometimes, in fact, all the time, we require to shoot to see the images in the biliary system. And so one has to be very careful and always be mindful to wear the gown and protect the person and also the whole team. So in the long run, nobody has any side effect of this. So when I'm looking at the picture, so this is the I would probably say a perfect picture of an ERCP. And so before we go further, there is a little bit of tips to say that the duodenoscope, the length of the duodenoscope is about 12 mm. So from that, we know the CBD diameter is about 7 to 8 mm. So from this, we can kind of like compare when we encounter the CBD dilatation, we can see whether it's really dilated or is it normal in caliber. So that is one of the small tips that I use in my practice. And then we can see the whole biliary tree here, which is lightened up, similar to what we see here. And sometimes they reference to the trees that you encounter in winter. So those who have traveled overseas, you can see there's hardly any more leaves left in winter. So this kind of like a resemblance to that of the biliary tree. And then this part is a spiral shaped tube connecting to the main bile duct, which what we call it as a cystic duct. And then there's this another tube which is now lighted up and then going across the spine. So this is what we know as the pancreatic duct. All right. So again, the indication, there are so many indications and I don't want to go into details of it. Basically, what it is when there's evidence of a blockage in the bile or the pancreatic duct, and it's already been identified by ultrasound or CT scan or MRCP. Of course, the blockage can be due to so many causes. Gallstone dropping down into the bile duct, tumors, strictures, or kind of an external compression whenever there's a growth around the liver or around the portal lymph nodes compressing the bile ducts, and then the bile ducts gets narrowed down, and the patient develops jaundice. So these are the common causes that we encounter. Again, another strong point to be stressed here is ERCP is used as a therapeutic procedure. It is not to do and diagnose what is the problem. Basically, diagnosis is done via other means, like I mentioned earlier, either by ultrasound or CT scan or MRCP. And then we use the ERCP for kind of like a therapeutic to address the problem. So again, a reminder to the nurses and of course the team which are involved in the ERCP, I have to make sure the patient has stopped the anticoagulant. In my practice, I normally suggest to the patient to stop aspirin 5 days before, or if they are on a warfarin or heparin or any other kind of anticoagulants, or at least 1 week before. If there's any allergy to the contrast, we need to notify. take note out of it. And I routinely give a dose of antibiotics, this maybe a second generation cephalosporins, and then substitute NSAIDs, about 100 milligram warrant before the procedure. And in my practice, I make sure that I get the consent from the patient, and in that consent, I will make sure explain all the risks involved before embarking the procedure. So now we're coming to the position. I do my ERCPs with the patient in a prone position. I'm used to this position, and I've been training in this way. I find it's easier to do, and of course the hand has to be beat the patient. And sometimes when you want to have that granular incision, it's on the hand, and there'll be some, it will be extended. There'll be some extension, so that it doesn't come on the way when I'm doing the procedure. So now you can see this patient is under GA, and of course this is the fluoroscopy machine at the side. So in the practice now, I've moved to performing the ERCP under general anesthesia or under deep sedation with propofol with my anesthetist around. I find the patients are more relaxed. Once the patient is more relaxed, the endoscopist or the surgeon is more relaxed. So you can take your time and do the procedure. Of course, there are in some centers, especially in the government hospitals in Malaysia, we still perform ERCPs with midazolam and pethidine given by the endoscopist or the surgeon. The reason being, of course, we do more procedures in government hospitals, and there's unavailability of the anesthetists because of they all are busy with their work. All right. So the problem with giving this midazolam and pethidine, they are all short acting. Sometimes during the procedure, the patient wakes up or the patient is not cooperative, especially the young male patients. So this sometimes can cause problems, and then you end up not completing the procedure. Now, going back to the position again, so you can see in this picture that I'm standing beside the patient, and beside me is my assistant, my sister, who's holding all the adjuncts. The monitor will be in front, and the anesthetist is standing on my far in front and the left, and the fluoroscopy monitor is on my left. So this is probably, for me, this is probably the ideal position that I can see both monitors. I can see the vital signs of the patient, and the assistant is on my right to help me out with the procedure. So on the table with the assistant will be all the basic stuff. Make sure the sphincterotomes are there, whichever that you currently use, or the endoscopies use most commonly. Mine will be the 39 mm. Then the guide wires are there, or even if it's not open, but it's there prepared. Some normal saline and contrast, gel, and also the balloon. So these are the basic things that are prepared on the table before the procedure. And then once things are out in check, then once we put in the duodenoscope, we can get to find the ampulla, the second part of the duodenum. And then the next will be to intubate it using the sphincterotome. So this is when the assistant becomes handy and helpful. So this is a short video that I like to show here, where this is the tip of the tritome, and then there is a cutting wire there. So the assistant helps into what we call to bore, to change the shape of the tip, so to kind of like get to the angulation to intubate the ampulla. So okay, so you can see that from the video. So it's either we do a minimal bore, sometimes you can call it to 1 to 6 or fully bore. So these are the things that we need to do, and the assistant has to be familiar with this type of steps. So this will help the endoscopist to kind of intubate the ampulla, which is one of the very important steps in ERCP. Okay. So next, once we are intubated, and then the assistant will try to forward the guide wire to the sphincterotome. It has to be a smooth and minimal resistance. If there's encountering any resistance, the assistant should stop, because if you keep pushing it, then create problems. Example like a false track or even perforation. So you can see from this picture here, once the guide wire is in and we inject a bit of a contrast, then you can see the baldak is nicely lighting up. Then we know we are safe, we are in the right track. So that's the thing. So once fluoroscopy is done, then come to the next important step, which is the sphincterotomy, which is basically using the cutting wire at the edge of the sphincterotome to cut the papilla and the muscles. The positioning will be, of course, the positioning of the sphincterotome is very important. So we aim most of the time at 11 o'clock. And then this is because we want to avoid the risk of bleeding and perforation of the duodenum. So we look at this video, a very short video. So I'm almost there. The guide wire is already in. So I know I'm already in. The guide wire, I can see the baldak there. So now I'm going to do the procedure to remove the stone. There's a small stone. There's a small stone there in the baldak. So before I put in my balloon, so I'm going to do the sphincterotome. So it's positioned at 11 o'clock. Sometimes you need to do some maneuver, you have to move to your right or move to your left. Then the assistant need to follow and keep that always that the cutting wire has to be as far from the duodenoscope, so it doesn't damage the duodenoscope. So once you have done, so you can see now it's been cut, bile is flowing out. How much to cut and all that depends on the endoscopist and his experience. Some gastroenterologists, they are a bit more conservative. The surgeons, those who are trained as a surgeon, they are a bit more daring. By the end of the day, the idea is to get enough big opening so that the stone can be removed without any other problem. Okay, so that's a short video on that. So sphincterotome, and the next one. So then once we know we have done the sphincterotomy is done, then just to forward in the balloon to remove the stones. So balloon trawl, that's what we call it. The size of the balloon will depend on the size of the baldak. From there we can adjust. We do it with the stone. If the balloon is too big, then we have a lot of resistance. Then you have a risk of causing rupture to the baldak. If it is too small, then the stone will slip through the balloon, then we will not be able to trawl. So once that is done, then we'll do an occlusive cholangiogram to make sure there is no residual stone. So you can see here, I've put in the balloon at the confluence, and then asking my assistant to inject some contrast, and then I'll trawl down very gently to see whether the baldak is very nicely lighted up. And then at the edge, once the balloon is reached at the edge, and then get a picture to confirm it. So there's no stones left. And then later, after the procedure, just to show it to the patient also to reassure that we have cleared all the stones. So that helps. So in the contrast here, you can see the balloon, the baldak is also getting lightened up. Now, this sometimes post-ERCP can cause some cholecystitis. So that's the other thing that sometimes we need to be mindful when injecting to the contrast, not to inject too much of a contrast, just enough to identify the baldak. So that's that. Okay, so just now I was mentioning about the balloon. So you can see here, this will be the half size. You can see there's a gap there. So once we push it in all the way, then this will become a full balloon like that. So this is how you need to communicate with the assistant, or the assistant has to communicate with the endoscopist when mentioning, when you talk about this, how much to inflate to get just the right size of the balloon to trawl the stones. So during the procedure, especially the patient is given a local sedation, the vital signs and the SpO2 has to be monitored by the assistant, at least our nurses. Very often, things can, we get carried away during the procedure. So looking at whether the stone is coming out, or we are able to do a nice cholangiogram, and then we kind of overlooked in that monitoring. So that's why it's important to monitor and make sure especially the SpO2 and the blood pressures are monitored well, because the sedation can affect their breathing. But of course, if the GA is around, then it's a less stress, because the GA and the team will be monitoring, the anesthetist and the team will be monitoring these vital signs. Okay, so that's part of the assistant's job. So I have just mentioned briefly about how do I go about doing an ERCP for a patient with a stone in the bile duct. Of course, there are so many other procedures that can be discussed, especially like managing a stricture, using a dilator, and all that. But I think due to interest of time, I think I will just keep it to that. So in ERCP, when we look at the complication, as I said, this is quite a challenging procedure compared to an OGDS or a colonoscopy. So one has to be mindful about the complication when doing the procedure. So the common ones are pancreatitis, cholangitis, bleeding, duodenal perforation, and in rare cases, even a bile duct perforation or forming a false tract. Now, when we talk about pancreatitis, it's quite not to say it's quite common, but among the complications, this is one of the things that we do see. But most of the time, it is self-limiting. There are about 3 to 4% of the patient can get into a severe pancreatitis to necrotizing pancreatitis due to ERCP. So that is the reason that we have to keep an eye on this patient post-procedure. If they complain of abdominal pain, need to get an amylase level checked. And then when we are doing the ERCP, try not to either even cannulate the pancreatic duct, or even if that happens, try not to even inject contrast into the pancreatic duct. But having said all that, I think over the years I've seen, despite whatever you try to do, sometimes they do get pancreatitis. But when they do get it, I think it's important to reassure the patient and monitor them in the ward. And I feel that most of them, within 24 to 48 hours, it settles down. Cholangitis, because the system is blocked because of the stone or the tumor, now we are unblocking the system. And then there's a shift of bacteria, lymphovascular kind of a permission, which leads to patient getting infection. It can be a full-blown cholangitis, especially when the ESP is done on a prolonged time, multiple times trials, and a lot of contrast are injected, or sometimes there's a pus in the bile duct. So when this kind of a scenario, even the procedure is done, stones are cleared, I still put a stand just to make sure that bile duct is patent, and then we avoid the cholangitis, because at times when there's multiple times the procedure is done, what happens is the bile duct becomes edematous, and then that impedes the bile flow, and patient can go into a full-blown cholangitis, which can even go into patient getting intubated and organ failure. So ideally, if there's a cholangitis and if there's a pus, better to if you can clear the stone, clear the stone. If not clear the stone, just put a stand and come back the next time and repeat the ERCP. But if you do decide to clear the stones, after clearing the stone, ideally put at least a short stand until the cholangitis settles. Bleeding, this is mainly, as I mentioned earlier, and then I'll show you back later how I deal with in the troubleshootings. Duodenal perforation is not common, but it does happen. When it happens, it causes a lot of morbidity to the patient, unless it's in the D2 or D3 part, which is retroperitoneum. Then sometimes you can get away with conservative treatment. Bile duct perforation and faucets are very rare. These are most of the time due to a false tract, or kind of like a very aggressive handling or manipulating the bile duct. So again, just a brief mentioning about the bleeding. So you can see in the picture the anatomy. Understanding the anatomy is very important. Although mainly for the endoscopies, but since the assistant is going to be with the endoscopies all the time assisting, so kind of like it also helps if the assistant understands why are we doing certain things in certain ways. So the 11 o'clock is where, like I can see in the picture, where the bile duct is like kind of situated. So we try to aim to around that area. the main vessels are around 3 o'clock and 9 o'clock. And so we try to avoid around that areas to kind of like avoid any torrential bleed. So if it is done, most of the time, even if there's a bleeding, it will be just for temporary. It is amenable with some certain procedures which are come back later. The perforation, as I mentioned earlier, this is just a classification. Most of the time, the perforation will be, if it's a retroperitoneal, which is around these areas, T2, D3 areas, most of the time we can get away with conservative treatment because it's retroperitoneum. But if it happens around the sphincterotomy site or even in the bile duct, it probably requires intervention. And if it's this one, the type 1, then this, if it's intraperitoneum, there's a duodenal content in the abdomen, then the patient will need a laparotomy. Okay, so I'll come to the last part, troubleshoot. The first one will be the endoscopist cannot intubate the pylorus. Scope, most of the time it's because the scope is looping. It's either we have inflated too much air, and then most of the time, what we need to do is to reposition the patient either in the left lateral or supine, and you can get away with these maneuvers. Difficult cannulation, that's also another common problems that one will face. So when the time when you want the guide wire to go to the bile duct, it happens to go to the pancreas again and again. So end up you do a double wire technique whereby you keep the guide wire in the pancreas and then we put in another guide wire to the bile duct. And then if required, sometimes we need to put a PD stand, but I find at least in my practice, I can get away with just a guide wire. Pre-cup papillotomy, there's something that some endoscopists do. It is like doing a pre-cut at 11 o'clock and then trying to open up the papilla before introducing the guide wire. I don't normally do this because I find it, what happens is if you cut and if you don't cut it properly, then the opening, although you find there's an opening, but then you end up having forming a false track. So if this thing doesn't work, then you can always come back about 24 to 48 hours later after a high dose of PPI, which just works a time for me. And then when all others fails, and then we get our interventional radiologist to do a PTPD. When facing with large CBD stones, we can see that in MRCP or CT scans. So we need to have the adjuncts prepared, like the trapezoids. And then with that trapezoid, we can crush the stones with a mechanical lithotripter and then try to kind of remove the stones. So this is the trapezoid that I use in my practice. So you can see here, I hope the video is working. Not very clear, but here I've already inserted the mechanical lithotripter and I've already opened up the mechanical lithotripter to try to catch the stone. So just have to go and wriggle out in the bile duct, and then the stone will get stuck to the trapezoid. And then once the assistant says yes, you can feel cannot close completely, then we know the stone is already in the lithotripter. And then slowly bring it in. And then once you see the stone is already there, some endoscopists will try to pull it out. I don't do that because I find sometimes you can get stuck at the ampulla. So I will use a lithotripter and try to crush the stones, and then just flush it with salines, and then use a balloon to kind of like troll all the remnant stones, which is, I think, at least in my point of view, is a safer procedure. Okay. Bleeding, as I mentioned earlier, happens after the sphincterotomy or balloon troll. And then as long as we are not hit the vessel, if it's just bleeding from the cut surface, we just do a compression with the inflated balloon at the side of the bleeding for a while, maybe about 20 seconds. And most of the time it will stop. If it doesn't stop, we can inject with the saline or adrenaline to create a tamponade. And if all that even with these two procedures, you still find there's still a bit of a oozing, then can still put in a single or double stent just to create a tamponade, and then eventually the bleeding will stop. Okay. So basically, I've come to an end of my presentation. ERCP is a teamwork, although the endoscopist does most of the work, but you need to have a good team. The nurses, the assistant has to be trained, has to be well versed with what you're going to do to have a smooth procedure, and also to maintain the patient safety. So with that, I end my talk. And Mary, thank you again for this opportunity. And I'm happy to take any questions if there is. Thank you.
Thank you, Mohan. Very nice, straight to the point. I think both Mohan and Masfik will agree with me that senior nurses who are assisting you, sometimes they know what to do before you even ask, and they make your life so much easier.
Yeah, you're right. I mean, even I depend on my nurses, at times, because sometimes you're too engrossed in that procedure, and you need another pair of eyes to tell you what to do or what not to do, kind of a thing. So it's important, and it's always safe to have another assistant who's well trained. So it's like a journey, it takes time, and then you have to make sure that whoever that you have trained, they are with you.
They don't leave.
Yeah, they don't leave. Otherwise, you can start back the whole procedure again.
Like our first speaker today, Miss Sarah, she does ERCP with me. So very good stuff. Whenever we cannulate the PD, she already know, no need to say, she'll remove it by herself, and it makes the procedure very smooth.
Yeah.
I think Masfi, you'll agree with me, the assistant very important.
Yes, definitely. Yes, Manasundaram, very Sundaram presentation.
Thank you.
And I want to add one point that they can create the whole procedure smooth, and they can also make the procedure difficult also. If they replace the wrong forceps, he will stuck. So I faces this problem also. My assistant, I tell him that give me this forceps, and he actually did not give the crusher, rather give a dormia forceps. Then I stuck in the CBD.
Yeah.
Then what happened? Then I have to do the spyglass cholangioscopy. Then I have to crush this whole stone. Then I have to remove this.
Okay, I think one of the way to overcome this is probably like for the endoscopies, right? As for me, you try to use the same thing and then try to keep the procedures with not much of a variation. So I think even once you have done that, and then so the assistant will also have the flow of thoughts will become much easier. Then they know this is exactly what is happening. So if you keep changing one day this, one day that, one day that, and then they also get confused. So that helps, I think, in some way, and that's even, in fact, that's the same thing I do in my surgery. So keeping things with a clear SOP and using the same stuff will help the assistant to know how to assist better.
Of course, sir.
All right, thank you, guys. Okay, we've come to our last speaker, someone who needs very little introduction. Dr. Lau is a consultant upper GI and a bariatric surgeon in Pantai Hospital, and he'll be talking to us about something very specific, and he's one of the pioneers, I think, in our country to, steer this procedure forward. So, Dr. Lau, off to you for your talk. Thank you.
Thank you very much, Mark. So I'm the last speaker. Hopefully everybody is still around and not too fast to sleep. So let me share the screen first. Okay. Can you see it?
Yep,
Can everyone
see.
Can okay.
Yep.
All right. So let's start. So the last talk of the day will be on POEM, EMR, and EST. So actually the topic given was EMR and EMR and POEM, but I guess probably people will be talking about EMR and EST and POEM lah. Because most of the time when we talk about EMR and EST, sometimes the nurses do confuse between the two, correct? So let's go. So this is the outline. I'm going to touch a bit about EMR. EMR is actually endoscopic mucosal resection. And then we have ESD, which is a endoscopic submucosal dissection. And now we have some extension of ESD. We call it EFTR, where you have an endoscopic full thickness resection. And now the newer procedures will be POEM. POEM is actually what we call as third space endoscopy. So POEM stands for per oral endoscopic myotomy. Is used to treat achalasia, and as a result of doing third space endoscopy, we have expanded the indication to even doing smaller submucosal tumors. So the procedure is called POET or STIR. So some people call it submucosal tunneling endoscopic resection. So they go into the tunnel and take out the tumor from the submucosal area. And now there's another branch of endoscopy. We call it bariatric endoscopy, where we can put balloons and also do stitching, but we won't touch on that. So for the benefit of the nurses, so that they know, it's called endoscopic sleeve gastroplasty. So these are the various procedures that we can do in the upper gastrointestinal tract now, and probably more and more procedures are coming up anyway. So we're just basically going to touch about EMR, ESD, and POEM. So what is EMR? So EMR stands for endoscopic mucosal resection. It's basically designed to remove any lesion confined to the mucosa. So anything on the mucosa, we remove it with a snare. It's basically something like an EMR already. So there are many types of EMR. So the most common type would be your inject and snare. So that would be either you use a hot snare or a cold snare. So you call that a hot snare EMR or a cold snare EMR. All right. You can even have a cap assisted, where you suck the lesion into the cap as shown in the diagram, and then we snare it off. That's a cap assisted snare in an EMR. Or the band ligation assisted snare EMR, where you suck the lesion into the cap and then put a band below it and then snare it off the band. So the example commonly used in our country would be the duet EMR. The set is actually by a Cook. So usually I commonly use that to remove Barrett's nodules, or sometimes the Barrett's mucosa. Okay, so what are the pros of EMR? So it's actually a much faster and a shorter procedure compared to ESD. So my nurses will be very happy if you tell them we do EMR and not ESD because very fast. They don't like long procedures. And also it's a lower cost. And sometimes if you are unsure of the diagnosis, rather than just taking biopsy, straight away do an EMR sometimes it's diagnostic and therapeutic at the same time. Let's say if you have a lesion which is dysplasia, you take some biopsies. Sometimes you can just straight away do an EMR, because EMR is a quick procedure. You don't really need general anesthesia unless you're going to do a longer procedure. So it's easier to perform and also technically less demanding compared to ESD. All right. So this is an example of a lesion where I use a cap EMR to remove it, the duet. So you can remove roughly around a size of 1 cm to 1.5 cm. So the limitation is we can't take out larger lesions. If we want to take out larger lesions, let's say there's a long segment of Barrett's, but you have to resect it multiple times. Then the problem is you get what you call as a piecemeal resection. So it's not ideal for HPE, because you don't get one large specimen, you don't know where is the margin. So it's not good for pathological staging. Let's say if that one is a cancer, you won't know whether you have actually got all the margins out or not if you're going to take it out in multiple pieces. Okay, so because of that, you tend to have a higher recurrence rate, even for dysplasia and also early cancers if you do EMRs. Okay, and as we mentioned just now, potential for incomplete diagnosis, and it's not really suitable for cancers unless a very small one, maybe less than 0.5 cm, then you have got it out and margins are clear, then yes, you still can do that. So because of those limitations, the Japanese guys designed ESD. So ESD is an endoscopic submucosal dissection. Okay, so what we do in ESD is actually we remove the whole specimen and block, and we need to use a knife to remove it. So the advantage of ESD is because there's really no limitation to the size. If the endoscopist is very skilled, I've seen people removing like a 10 cm lesion also. Okay, and this is very important for cancers. So sorry, at the side there's you see that there's one of the larger lesions that I've managed to remove is roughly around 5 centimeters. But it can actually some people have removed up to like 8 centimeter, 10 centimeter lesions. The only problem is it takes a long time then the nurses will be very frustrated. Why are you taking like 4 hours, 5 hours doing this procedure? Okay, but it's more accurate for HPE and also more accurate for staging. And actually for early cancers, you can sort of like stage 1 cancers, especially T1A tumors, we can actually avoid surgery, and it has lower recurrence rates. So at the moment, for T1A cancer, that means confined to mucosa, EMI is indicated. For T1B, is actually still a gray area. There's a lot of debate on it, so I probably won't touch on it. So I probably will not recommend it for T1B. But I can say, if you're thinking that the tumor has gone into submucosa a little bit, maybe the muscularis mucosa, still can, but might as well just remove it, send it off. Then you see if it goes deeper, you will know halfway when you're doing the ESD, sorry, halfway you're doing the ESD, you can't cut it off already. You see a lot of fibrosis or you can see the tumor down there, then you know, okay, this tumor is actually gone deeper. Okay, so what are the limitations then of ESD? It's technically more difficult to do. Takes a long time to learn, also longer and steeper learning curve. And obviously the procedure time is much longer than EMR. Sometimes it take hours. I have a colleague who sort of took breaks in between the ESD because the ESD took like 8 hours or 9 hours. He went for a quick break and come back and continue on with the ESD. And of course, there's a higher risk of complications for ESD, like perforation and bleeding. The risk for EMR is actually much lower. All right. And these are the types of knives that we can use for ESD. So basically, we divide the knives into 3 different types. The most common type is the needle type knife. So you can see from the diagram there, A. So the needle type knife is like in the diagram is the dual knife, okay? Or you can have the TT knife where you have a triangle tip, or you can have a hybrid knife, the circular tip, and the other one is a flush knife from Fuji where there's a ball tip, okay? The second type is the insulated tip, where at the end of the knife, there's an insulated tip where to avoid damage to the submucosal layer. So usually when we use the needle type knife, we push the knife. We push. So there's a higher risk of perforation. Whereas if you use the insulated tip knife, the ball tip type, the energy won't be concentrated at the tip. It's just only on the knife. We pull it, we drag it. So that one is actually safer. Some people, they use a combination of 2 types of knife, but it adds on to the cost. So if you're very good, you can just use a needle tip knife. But if you want to make it faster, you can use the needle type, or you can use the insulated tip, which is the IT knife. The scissor type knife is good for cutting, but that one, it depends a lot on the assistant to close the jaw. I have not used it before. That one is available from Fuji. But I think in Malaysia, I haven't seen it before yet, but it's available in the market, the scissor type knife. Okay, so as you can see in the diagram, you can actually remove a huge specimen by doing ESD. All right, so sometimes, let's say a surgeon a bit lazy, so they can do what is known as the hybrid EMR ESD. So once you've cut around the lesion, you've cut around the margin already, then you find that it's too long already, the procedure, or difficult to maintain traction. So what is left in the middle are those flimsy fibers in the submucosal area. Then they can take a snare and snare it off. So it's called a hybrid EMR ESD. The only problem with this hybrid technique is you may compromise on the margins only. So you ESD, you cut out all the margins surrounding the mucosa, so the thing is free. Then you trim all the submucosal fibers until like somewhere in the middle. Then you just use the snare and just snare it off. Sometimes you'll bleed because you just whack out like that, but you can still burn off all the blood vessels. Okay, so the only issue is margins, and may not be as good for pathological staging if you do a hybrid method. Okay, So next, we go on to achalasia, which is the procedure we're going to talk about is POEM. So achalasia actually comes from the Greek word, which means do not relax. It's actually a primary esophageal motor disorder. And I always tell the nurses, so you always see people got GERD, hiatus hernia, right? This is the opposite of GERD and hiatus hernia. This is where it's tight. Okay, so the procedure is used to treat achalasia. So the key feature of achalasia is there is a non-relaxation of the lower esophageal sphincter. It doesn't relax and there's no peristalsis. So this is not a very common disease. It's rare. It's 1.6 in 100,000. And normally, how do we diagnose achalasia? We use manometry to diagnose achalasia. So this is the normal manometry, and this is the manometry where a patient has achalasia when you can see that there is no peristalsis. Okay, so basically, to treat achalasia, POEM is one of the newer methods to treat achalasia. So POEM stands for per oral endoscopic myotomy. It consists of 4 steps. Okay, it's a procedure popularized by the Japanese surgeon, Prof. Inoue. And the first step is actually to make an incision and go into the submucosal space. And then the second step is we create that tunnel in the submucosal space. And then the third step is we cut the muscle. And the fourth step is to close back the muscle. So if you can see from the diagram, we are actually not working in the lumen. So the nurses always have to be reminded, we are not in the lumen. We are actually in between the layers, in between the mucosa and the muscular layer. Okay. So these are the 4 steps. Mucosotomy, which means making the hole in the mucosa and enter into the space to do the tunnel. And then we cut the muscle, it's called a myotomy. And then we close the mucosa back. Okay. So in POEM, we purposely perforate. So most of the time, the nurses are very afraid of perforation because they say they have to write incident report. But in POEM, we purposely make a perforation. We go out and then we come back and close the perforation. Okay. And so far, the results of this POEM procedure is very good. And we find that the success rate now probably is even better than hairless myotomy. The only drawback of this procedure is around 20 to 30% of patients, they get reflux. Okay. So mucosotomy, tunneling, myotomy, and closure. Okay, so this is a short video of, I think this is a very old video already. So this is how we cut, we inject, and then we cut. We inject into the submucosal space and then we cut. Then we go into the submucosal space, then we cut away the submucosal fibers. Then the next step would be to create a tunnel. So we just cut away the submucosal fibers. We will go all the way from probably around, usually we take around 8 cm from the junction, then we go 2 cm beyond the junction. Okay, if we encounter big blood vessels, we have to use this device called as the coag grasper to sort of like coagulate the blood vessel first before we continue. If not, then you have bleeding. Then after we have created the tunnel, we have to come back and cut the circular muscles of the esophagus. So sometimes this can be quite scary because once we cut the circular muscles, the longitudinal muscles outside can be quite thin, and we can actually see outside. Sometimes you can see the aorta, you can see the peritoneal fibers, you can see the omentum also if you're going anterior. And finally, once we finish cutting the muscle, then we close back the defect that we have opened up with clips. And this is also another crucial step because we need to be able to close it up in a straight line to make sure that there are no gaps in between the mucosa that we open up. So these are examples where you have achalasia, esophagus dilated. These are very bad cases, already like sigmoid-shaped esophagus that we do. Okay, so next come to the troubleshooting. So what solution do we use for ESD or POEM? So most of the time, we need to use this solution called indigo carmine. Try not to use methylene blue because it stains everything blue and it's very hard to differentiate. So they always ask me how much to dilute. Usually I will just eyeball. I take around 2 mils and shoot it into a 500 cc of normal saline and LIC. Used to be I like it more blue, but now I think I like it a bit lighter color. And to add or not to add adrenaline, it all depends on the individual endoscopist or the surgeon. Nowadays I don't really like to add adrenaline because the anesthetic gets very jumpy, because sometimes the pulse rate will go up if you add adrenaline in, but it can constrict the smaller blood vessels and you have less bleeding. Okay, so what are other tricks that you can the problem with POEM is the difficulty in entering the tunnel. So one thing is you want to make sure that you have some thickening agents to make the thing last longer. So these are the things that you can add. If you have is viscoelastic. So viscoelastic is somebody like they use during ophthalmology, the surgery. So you just dilute it and inject it into the solution. It will make it last longer. So the fluid bleb in the submucosal space doesn't drop down. It doesn't tenggelam so fast. So you can actually take your time and do the tunneling, the incision, and also create the tunnel. Sometimes the problem is when in between injecting and changing instruments to the knife, the nurses or the newer nurses, they're a bit slow. Then the whole bleb will just drop down already. Then have to keep on injecting again. So if you use these type of agents, then your bleb can last longer. Okay, you can have your HPMC gel or hydroxyethyl starch, hyaluronic acid, or even gelafandine. When I started, I used gelafandine, but I find that gelafandine creates a lot of bubble, so very difficult to see. So now I just look for viscoelastic, but it's very expensive. The only thing, you have to get the ophthalmologist to borrow you a bit, then you can use viscoelastic, then it will last longer. Then the other trick is let's say if you do ESD, once you cut out all the margin, if you see in the diagram, the thing is hanging, you know. It's not like doing surgery where I can have one hand to pull and then another hand to pull, that way have traction and counter traction. So there isn't any traction. So one method is you can tie like a suture or a dental floss to the clip, and then you leave the suture outside the scope. And then when you go in, you clip on the mucosa, and then you can pull on the suture so that this mucosa that you have cut a bit gets a bit of tension so that you can cut more. Okay, and the other thing for ESD is how to prepare the specimen. So this one is also another important step. A lot of nurses, when they are new, they haven't seen this procedure before, they will just take the specimen and dump it into the formalin. So what happens is the whole specimen will just shrink. Okay, so we don't want that. We need to pin the specimen onto a board. Okay, before we put it onto the formalin, you have to spread it out nicely. Why? Is because it's important for the pathologist to be able to read and for staging. Okay, if you just dump it, the whole thing will shrink and become one small piece. All right, so you can invest in boards. Earlier, I don't have board, so I just get the styrofoam board from the pharmacy and I just pin it on. Then recently, one of my colleagues found this on Shopee, so we bought this so that we can pin it on. So somehow they sell it online also. So we pin it on it so that it's nice because you can even see the measurements, how many cm there. Okay, and then the pathologists also appreciate it, so they can do it nicely and tell you. Okay. So for POEM and ESD, pretty similar. You can actually do it in the endoscopy suite or in the operation theater. Back in the government hospital, we used to do it in endoscopy suite. We just give GA there. In the private hospital, now the hospital got some issues. They don't want to give GA. I mean, those are administrative issues lah. I think can be sorted out. So the directive is we cannot have GA in endoscopy suite. So we have to do the procedure in the operation theater. So ESD and POEM usually done in operation theater. Very rarely, sometimes if you have a small lesion, you want to do ESD, you can kind of do it under deep sedation, possible. But I probably would still prefer to do it under GA because you have more control. Okay, and make sure you use CO2. The nurse's job very important to make sure that the air is off, because we're going to insufflate a lot, so we don't want the air to escape out of the lumen of the bowel into the peritoneum. Okay, and then they will get a lot of emphysema if you use air. All right. The position to use is usually for POEM, I will do a supine position. If we do ESC, it depends on the location of the lesion. So that one have to ask your endoscopist or your surgeon what position they want to put the patient on. Most of the time, you can use a standard gastroscope. for ESD in the colon, you can use also a standard colonoscope where your H190 is also adequate for the Olympus scope. But because we are working very near, now with the newer scope like the EDOF scope, you have it actually gives you a very, very clear vision if you do have it. Okay, and for achalasia patients, for POEM procedures, most of the time you need to do what we call as a pre-procedure lavage, because even though I tell the patients don't eat, you just drink liquids for 1 or 2 days before the procedure, they will still makan something or the food takes a long time to go down, because in achalasia, the junction is tight, so the food doesn't go down, so there's a lot of retained food. So we need to lavage out, clean out all the food before we can actually do the POEM procedure, because we are going from a dirty area into a clean area. So we have to make sure that the lumen of the esophagus is really clean before we do that procedure. Okay, and here are some pointers for the nurses. Most important, make sure CO2, because I encountered a few cases earlier on in my learning curve of POEM. The nurses always forget to turn off CO2, and because they're so used to using air, turn off the air. So they're so used to using air, so they forget to turn on the CO2. So in the end up a lot of bloating and not issues with the anesthesia side. Okay, and listen to the surgeon or the endoscopist for the instructions, like whatever knife they want to give, want to clip or don't want to clip. Okay, and when you control your knife, you have to make sure that your knife is either fully in or fully out. What I find is some newer nurses, they're not sure, so they put halfway. So you can actually see that the knife is only half out only. So you have to endoscopist or the surgeon have to tell the nurse it's either out or in. There's no in between. Okay, and the other thing I find that my endoscopy, sometimes the new ones like to do is they stand in front of me, so they block my view. Okay, because I know why they stand in front of me is because of the way I hold the scope. It's easy for them to insert the instruments into the channel, but don't stand in front of your surgeon or the endoscopist, because then you will block their view and it makes it more difficult for them to do. Stand behind, and then you have to pass the knife and put it into the working channel. Okay. And before we start the procedures, ask the surgeon what are the requirements, what are things that they need. All right. And especially for this type of ESD procedures, you can prepare a dental floss if they want to do the traction method, or also a long suture, okay, so that you can pull it all the way out to the mouth. Okay, so these are the settings that I use. Everybody use different settings for POEM. This is the older machine, the ERBI 200. The ERBI 200 only got the force coact and strive coact. So I use endo cut to cut. I use this force coact mode to burn. But this one is the newer machine, the ERBI VIO3. It has a spray coact mode, which makes the POEM much faster, because the spray coact is like the spray mode in surgery. You just the thing will just fly, the sparks will fly, and then it moves faster. And you can also program it to, like, you can do incision, certain modes, tunneling, hemostasis, and other modes that you can program it. So it's actually very useful if you have this newer ERBI machine. And for POEM, usually I use the tapered cap. And one tip is I tell the nurses now is make sure you tape it, okay? Because let's say if you recycle it, like when I work in government hospital, we used to recycle these caps. The thing can drop out in the tunnel, so we don't want that to happen. So we tape it onto the scope. So it's a good practice to sort of tape it onto the scope. All right, and you can prepare. So basically, if you do a POEM procedure, you only need these 4 instruments only: your injector, your knife, either a TT knife or your IT knife, your coagulation grasper for hemostasis, and then a clip. Okay, the clip depends on whatever clip you want to use. This one is the older one where you have to reload the clips. Now the new ones, you don't have to reload the clips. It's just a single long clip where you can turn it. It's much better, but of course more expensive. Okay, so this is the triangle tip knife, which I like to use because it has like a triangle, so I can just hook onto the fibers compared to the round tip. Okay, so usually this is how we position in OT. Supine position, my nurses is at my side or behind. Try not to stand in front of me, and then your monitor you try to put in front of you so that you can easily look to the monitor. So you don't have to bend your head. Sometimes the nurses they like to put the monitor at your side. So every time you do, you have to bend your head. Then after some time you get neck pain already. Okay. Then for defect closure, actually, if you use smaller clips, is better because you get more control with the smaller clips. Because when you want to close the defect for a poem incision, you want the nurse to sort of like slowly close the defect, then only you hold tight and then you fire. What the nurses have to do is, because they're so used to clipping blood vessels, they will just very fast. So if you imagine, if you are like doing surgery, if you close very fast, the mucosa will just slip out, or they may just catch one side. So I always tell them, you close slowly, then you can see, okay, the mucosa opposed already, then you hold tight, then you fire. Okay, so if you want, you can use a combination of small and large clips, because if you use the larger clips, you don't have to use so many clips. Okay, and we always close in a straight line, and we try not to overlap the clips. So if you have clip overlapping each other, then the next clip become very difficult. So we have to put the clips like this next to each other, straight line, like in the diagram. Okay, so finally we go to the risks and complications. So like any other procedures, POEM and also ESD, among all the endoscopic procedures, I will consider this as actually quite a high risk procedure. But once you have overcome the learning curve, all this become rather minimal already. One of the risks is bleeding. So sometimes when you have bleeding in a tunnel, can be quite difficult to see. So what do we do is just push the scope against the bleeding. Most of the time you will slow it down a bit, then you just wash with water jet, then you can see already, then can use the coague grasper to stop the bleeding. Okay. Perforation, because you're already creating a hole there, is not really a problem. What we worry is actually the mucosal injury at the junction. So if you have a mucosal injury at the junction, what you can, it becomes a true and true perforation, because you have a hole in the mucosa. Then if you do a myotomy, you cut a hole in the muscle, then you're to the outside of the peritoneum already. So if you do have a hole in the mucosa near the junction, you can still salvage it by putting some clips there, but then of course then you have a few sleepless nights. Okay. But most of the time they are quite okay one. The clips hold quite well. All right. The other issue is if you blow a lot of air, you can get pneumomediastinum, and also subcutaneous emphysema. Most of the time, the subcutaneous emphysema they settle on its own. For if you get pneumothorax, you can still put in a chest tube. Okay. The other thing I encountered before is a retained foreign body in the tunnel. I have one instance, the cap dropped out. I sort of have to recap in the tunnel. Another time, what we had is the white part of the older clips where we need to reload one. It sort of dropped out into the mediastinum, so we cannot retrieve it already. But somehow the patient turned out okay. It's not the metal bit; it's that there's a white plastic sheet. So it can happen when you have a retained foreign body in the tunnel. The last one is the CO2 retention. If you blow too much CO2. So for the newer endoscopies, don't keep on pressing on the CO2. There is actually a low flow catheter which the nurses can actually buy. So you can put it at low flow so you not so much CO2 comes out from there. All right, I think that's all. So in conclusion, I feel ESD POEM are complex procedures, and these procedures are all done under GA. So needs your anesthetists to support. And I cannot stress enough, all these procedures needs to be done under CO2 with CO2 insufflation. Okay. And as the GIA or nurse, your role is actually very important to ensure the success of the procedures, because you control the clipping, you control the knife coming out, so you control the injection. So your role is actually very important. You are like the assistant to the surgeon in surgery already. Okay, so with that, thank you. I'm happy to take any questions.
Thank you so much. Very great talk. Something that many of us are not very familiar with. Okay, I got one question from one of the participants. He's saying this is considered advanced endoscopy. So asking whether is this in the KKM curriculum, or if it's not, can they any centers which they can go for training
Okay,
post basic?
Because I don't know the nursing curriculum, but under the gastro trainees, they nowadays they are learning all this already. So there are few centers which do this, as far as I know, the previous UM does this. UM does quite a bit of POEM, ESD. The other center that does it is HKL. They used to do, but not a lot of volume lah for POEM. HKL does some POEM. Queen Elizabeth also did quite a number, I think, but not many cases also. So these are the few hospitals in KKM that I know. Even in private hospitals, also not many hospitals doing it. So it's still very relatively new, but I can foresee maybe in the next 5-10 years, because the newer batch of fellows, they went off for training. By the time they come back, they will have learned it already. So they would start doing it. So the nurses will be exposed to it. So I also had some problems with initially to start off in private hospital where the nurses are not familiar. It took a long time to do one procedure, to the volume took like 6 hours for the first time. But now it's like 2 hours, less than 2 hours already every time. Because earlier they're not familiar what equipment to do, how to set it up. So it's still it's a learning process. Yeah.
So they'll need to go on their own, basically for now, attachment or something.
Yeah, previously I think if they go to centers where they got these procedures, then they will be exposed to it. The problem is not many hospitals are doing it in KKM.
Yeah, one question by me. Once you close the defect, how long you have to fast them or something?
Okay, that one is very subjective lah. Usually, routinely, what I do is I tell them liquid diet for 2 or 3 days. Then I will routinely do a contrast swallow on the second day to check. One is to check the defect, got any gaps or not. The other one is to check with the flow down to the junction, whether it's successful or not. I mean, after doing so many, some people will say there's no point in doing contrast swallow. So what's my yield? So far, I've picked up one where there is a small little leak which goes into the tunnel. So what did I do? I just fast the patient longer. Then after 2 or 3 days, I repeated the contrast solo, healed already. No
They
more
heal
already.
very fast anyway.
Yeah, it healed quite fast.
Yeah.
Yeah.
Okay, so I think we have come to the end of the session. Thank you all so much for spending your precious Sunday with us. It's very informative, and then we hope to do more in the future and then add on more interaction and more advanced procedures. Okay, so thank you once again. If I may get you all to open your camera, we'll just have one picture for remembrance.
Send it to me also.
Sure, definitely. Okay, ready? 1, 2, 3. Okay. So thank you all once again. Thank you for joining
All right.
us. And then for those participants, you need certificates will be sent to you. So just if you don't receive it, just check with our secretariat again. So thank you guys. Thank you once again.
Thanks, Mark.
See you all. See you.
Okay,
Take care.
thanks you.
Bye.
Thank you.
Bye.
Bye.
See you, Masvik. See you.
Bye, Mark.